One of the mainstays of urologic practice has been the management of genitourinary tumors. Historically, the majority of these prostate, kidney, testicular, or bladder neoplasms have been surgically managed with very little to offer for the unfortunate patient who failed this definitive therapy. The lone exception was the pioneering work of Dr. Larry Einhorn at Indiana, who in the 70s and 80s combined cisplatin with other chemotherapies to treat advanced testicular cancer. As many of us know, this resulted in cure rates in excess of 95% when the treatment was combined with surgical management. Two major changes have occurred in the last decade. We've seen a rapid expansion in the number of oncolytic therapies across many tumor types. There has also been a consolidation of independent practices, with an ever-growing number of large groups forming in urban settings across the United States, and the development of centers of excellence within those practices. The net result has been that the urologic practice community has become more involved in treatment of advanced cancer patients. As we now move into a new area of healthcare, there are many unknowns. One thing, however, is certain. There will be payment reform with the abolition of fee-for-service and movement towards disease management and quality value-based outcomes. It will be paramount for urologic practices to look at new models of service to accommodate these changes. Strategies for early detection and screening, institution of treatment protocols, and the willingness to adopt new technology outside of our traditional surgical comfort zone will be critical to better manage our patients and ensure the viability of our practices. Flexibility and forward thinking are crucial for us to be effective in providing the best quality care to patients while evolving well-managed business practices. Let's talk a little bit about different urologic practice models and how these might affect patient care. In the past, we generally spoke of academic versus private practice. Now, the popular vernacular seems to define employed versus self-employed physicians. Employed physicians, in my mind, would include the historic academic physician as well as those who have been hired directly by a hospital or hospital system. I think this latter group represents the largest growth over the past few years as the market prepares for the creation of ACOs or accountable care organizations. The self-employed group would include the ever-shrinking number of physicians in small groups as well as those in large practices, which LUGPA, the Large Urology Group Practice Association, defines as more than 5 urologic providers in a practice. So let's begin our discussion with our panel's own experiences of effective management of oncology care in terms of how it's utilized within their practice. What practice models are out there today? What seems to work well? What does not? Dr. Crawford, let's begin with you. Can you describe some of the different academic models and how you deal with training residents and fellows regarding the use of systemic therapies at your institution and in others?
Sure. I'll give you a little bit of history. Since I've completed my fellowship at UCLA a number of years ago, I've been at several academic institutions, and I've seen sort of an evolution of urologic care, how it's changed over the decades. And when I first started out, we were kind of in urology clinics, which initially was non-paying patients with residents, and that's how we taught residents and so forth. It evolved into a sort of a private practice-like clinic where we'd have the residents come in. And the further evolution, at least at our place, when I came in the late 80s, was the development of a multidisciplinary approach. And I think that fits with what you said earlier about the focus being on disease management. Because disease management involves multiple specialties. And when you can integrate this effectively, you can see results not only with patient satisfaction, but with outcomes. And it also is a great environment to educate residents and fellows. And so we have, for instance, have a multidisciplinary GU oncology clinic which involves not only urology, but medical oncology, radiation oncology, pathology. A couple of things stand out. One is, as I already mentioned, patient satisfaction. It's sort of one-stop shopping. Even though we're independent, occasionally we do send a patient to see somebody else and they're in the clinic and get a consult. The other thing is what happens. And in our clinic, and this, we're not the only place where this has been shown, is that when you have this sort of care, your outcomes are better. Not only surgically, medical oncology-wise, clinical trials, but also survival rate. And if you look at our survival rates for various stages of cancer, even early cancer, in our clinic versus the state of Colorado, it's better by every level. And this has been shown actually in Philadelphia and Gamella's clinic and others. And I think you're seeing that with a lot of the large practice groups are the integration of care with more people and the outcome. And the way we're going in medicine right now with disease management, I think it makes sense.
Mark, tell us what you all are doing in Kansas City in terms of your group.
Well, we have a large urology group. There are 18 full-time practicing urologists, and we have 5 non-physician providers who facilitate some of the care. In our large center, we have an infusion center now where we can offer patients advanced treatments such as Provenge. We're developing a bone clinic where we can treat patients for bone health with some of the newer bone stabilizing agents. We have an active research area where we can put patients on protocols and discuss research. And we have an integrated office, not just with a single specialty, but with radiation oncology, pathology, and imaging. So we're able to recreate some of what Dr. Crawford is talking about in an academic setting within our own central office.
You know, that seems to be the model that's being recreated. I know, Neil, you've got that in Myrtle Beach, and Paul, I know you've recently gone from a 7 to a much larger group now, and I think that seems to be what is happening across the United States in the community setting, is to try to recreate in the community setting what is happening, obviously, that's been in place in the academic institutions. Let's talk a little bit about the cultural and philosophic differences that exist in terms of advanced cancer care. And Neil, why don't you give us your thoughts on that?
You know, you said something early in your introduction which was very striking to me, and I thought for someone like Dave, who's been in academics and you've been training residents for a long time, and that this demographic epidemiologic change in either joining a large group or being employed by a hospital. And we're all old enough to recognize that I think everybody originally came out and you either went into academics or you hung a shingle. And I think this concept of hanging a shingle might be better heard on Jeopardy. What does it mean to hang a shingle? I don't think guys in their early 30s and 40s may not even understand that that's what solo practitioners did. And I think that's gone. And there's a lot of reasons why that's fading away, that ability to be a solo practitioner. And your question about handling systemic therapies now for our patients with, geo-oncologic problems is the incredible explosion and diversity of therapies, which we're going to talk about today. In juxtaposition to the economic burdens that we have on us to run a practice. So the idea of being a solo practitioner or in a onesie, twosie is so hard now. And then to be in a bigger group, sort of maybe perhaps like the academic model, maybe even better than the academic model in that in true integrative care in a large group in the community that can really be facile and nimble in understanding new therapeutics, especially in oncology and in our field of urology, where there's been this explosion of opportunity and a need for understanding is something I think will be great for us to talk about later today.
Paul, I know historically you've been in a 7-person group, and I know now you're going through this merging process with another group to take you into sort of a moderate size. Do you feel like there's going to be any practice differences in terms of philosophy, culture, how you're going to move your newer partners into where clearly your existing group's already been?
Well, I think the challenge going forward is because of all these new therapies that are not cytotoxics. So they suddenly open up a whole new realm for us that we didn't have before. And with my group, when we started off with 7, there was certainly a slow acceptance of we want to have a standardized pathway, we want to have a standard program to manage people. And we slowly, over a period of a few years, migrated to having a bone health ADT clinic where everyone could have more uniform care, and we would identify an expert to say these people are at the next level, especially with these new non-cytotoxic therapies. The issue for me and the challenge will be when I get to 12, can I easily integrate 12 people rolling along with that same model of this is the way we do it, very integrated from the standpoint of we all do it the same way, and not so much like Dave's comment about having this multidisciplinary clinic, but could we just get everyone in a clinic to do everything in a uniform manner? And I think going forward with ACOs, can we have a better pricing of what we're doing? Can we set up an algorithm that we think, from our interpretation of the literature, for our patients is the best and most cost-effective way to go?